Hello, dear students. We have the next lecture with you today at number 5. The lecture is devoted to a rather topical disease that is treated not only by orthopedic traumatologists. First of all, of course, orthopedists are those who consider themselves such, but also to a greater extent general practitioners, district therapists. Sometimes neurological doctors and rehabilitologists are involved in this. That is, in fact, a very urgent topic. These are degenerative dystrophic diseases of the musculoskeletal system, such as osteoarthritis. Sometimes it appears under the term deforming osteoarthritis. So, what is osteoarthritis? Osteoarthritis is a multifactorial chronic progressive disease characterized by an imbalance between anabolic and catabolic processes, primarily in the gyre cartilage. That is, it is a disease of the cartilage tissue of the joints. In addition to the gyre cartilage in osteoarthritis, the synovial membrane is also involved in the pathological process with the development of a recurrent sweep to one degree or another, as well as subchondral bone, articular capsule, intra-articular ligaments, periarticular muscles. In itself, the name osteoarthritis suggests that the disease is degenerative dystrophic, not inflammatory. Although in fact, the most striking manifestation of this disease is precisely the period when we have exactly the inflammatory process, namely synovitis, namely inflammation. Often, naturally, inflammation of an aseptic nature which occurs as a result of, let's say, the aggression of our immune system against the deceased, against, let's say, degeneratively affected tissue. Therefore, many people call this disease osteoarthritis. You remember that the end of it at the end of, say, the names of diseases is evidence of the inflammatory nature of this disease. At the same time, many believe that given the non-infectious nature of this inflammation, it is unreasonable to call osteoarthritis and reserve the name osteoarthritis. So the world has split, yes, and has cracked nicely in half between those who recognize the term osteoarthritis and consider it more correct, and those who mainly operate with the term osteoarthritis. I suggest, osteoarthritis, basically, is a name that is accepted abroad. In our country, people are conservative to a greater extent, and therefore doctors live by the principle of what is written about the international classification of the 10th generation of the disease, say, IC10. And there is still the term osteoarthritis and another term, deforming osteoarthritis. This is a degenerative dystrophic joint disease with primary degeneration of articular cartilage, which we have just talked about, yes, with subsequent changes in the articular surface and with the development of marginal osteophytes, which leads to joint deformation. Deforming osteoarthritis is the most common joint disease. Among all patients with joint diseases, more than 2/3 is this very osteoarthritis, which leads to joint deformation, that is, deforming osteoarthritis. Osteoarthritis affects a fairly large volume of the population, that is, officially, 10% of the world's population has this diagnosis written in their cards. It is found in half of elderly senile people, over 60 years of age. This does not mean that the remaining half does not have it. Just against the background of, let's say, the detectability of diseases, against the background of complaints, against the background of what we treat a person for, half of people over 60 years old are treated for osteoarthritis. The average age of patients when this disease begins to be fixed is 40-50 years. That is, in fact, a fairly able-bodied age, when people are at the peak, in the prime of their careers. And as such, it is a social disease in this case, which prevents a sufficiently large volume of the able-bodied population from living and working. There is no particular difference in terms of epidemiology, let's say, gender, that is, there is no difference between the sexes with the exception of one of the forms of osteoarthritis, this is erosive osteoarthritis of the distal and proximal interphalangeal joints. The thing is quite rare, but it occurs 10 times more often in women than in men. To the question of the etiology of osteoarthritis. It was said at the last slide that the disease is multifactorial, that is, in essence, the main theory of the occurrence of this disease is polyethological. There are a huge number of factors that are statistically associated with the development of osteoarthritis. And at the moment, more than 200 such factors have already been calculated. So, let's try to divide these factors into some groups. This is a chronic microtraumatization of cartilage and joint overload. Active sports. Keep in mind not physical education, but sports, especially professional sports, quite a crippling event, probably even comparable to working as a miner or with heavy loads, which well, let's say, in the army, that is, in military affairs may be present. The peculiarity of labor associated with the overload of a separate group of muscles and joints, that is, now, let's say we were talking about working as a miner. Overload of the joints of the upper limb. And in fact, as many as I have seen geological pictures of miners, especially those who worked a lot, in the face, the joints look terrible. Indeed, the joints initially suffer very much. An example may also be, for example, the work of truckers especially, that is, it may be long associated with vibrations, that is, microtraumatization, with driving, let's say, powerful, seriously vibrating cars. At the moment, fortunately, the work of such workers is already changing, and the cars themselves are already different. An example is the work of designers. This thing is found on the internet, there is such a term in the literature, but this is a rather outdated understanding. Now I will explain what a designer is in the understanding of people who wrote a textbook in the 80s and 70s. Pullman is such a big tablet, huge, wooden, on which the device fall. The ruler drives, drawing, and imagine that a person is constantly standing, constantly raising his hands up, he is drawing, yes, he is moving this rather massive structure. Naturally, his upper extremity joints suffered. At the moment, this can also be associated with those teachers who like to give lectures, they read a lot of them using a blackboard and chalk. That is, the hand is constantly raised and they really have an asymmetry in the load on the joints, that is, the right hand is loaded much more heavily than the left. Now a designer is working with a mouse at a computer is a little different. The next is neuropathies, or as they used to be called, neuropathies. Neuropathies can be associated with various diseases. An example is diabetes mellitus, in which they are often found. That is, concomitant pathology can lead in this case to the development of osteoarthritis. That is, the normal functioning of the joint depends on the tone of the articular muscles. If the proprioceptive impulse is disturbed, everything leads to a decrease in muscle tone, to an increase in the load on the joint due to the action of gravity, and so on, and, as a consequence, to the occurrence of osteoarthritis. Loads on the joint can lead to joint overload obesity. There is also such an endocrine, probably, the problem of the disease, which is currently the scourge of our civilization. Even in our country there are a lot of overweight people. What can we say about countries such as Western countries or the United States of America, where the culture of a peculiar diet, especially the use of fast food, has led to the fact that overweight people are very common and as a result, gravitational forces on such people press harder and deforming osteoarthritis, for example, of the knee joints in this group of people develops many times more often than in people with normal or, low weight. The next group of factors contributing to the development of osteoarthritis are congenital and acquired defects of the musculoskeletal system. Let's say that you are preparing a report to me in the course of cycles this semester and report to your fellow students a report on congenital hip dislocation, or as a predisposition to this is hip dysplasia. That is, poor development of articular surfaces, lack of proper support, violation of microcirculation under dislocations, yes, and as a consequence, violation of the correct distribution of weight indicators, yes, gait disorder, all this leads to, let's say, dystrophic changes in cartilage. This is an imbalance in the load of articular cartilage, as a result, a direct road to the development of osteoarthritis. Injuries and surgical interventions on joints. An example is the removal of the meniscus. Yes, this is a very rough example. Well, with all the desire, any injuries accompanied by damage to the cartilaginous intra-articular tissue ultimately contributes to the development of degenerative dystrophic processes in this area and, as a result, leads to secondary, so-called osteoarthritis. Inflammation. Inflammatory arthritis, plastic inflammation of an infectious nature subsequently leads to degenerative dystrophic problems with the very things that were susceptible to microbial invasion and as a consequence may subsequently contribute to the development of osteoarthritis. There is an exception, oddly enough, gonorrhea arthritis. It is not the most frequent now in pathology, but at one time, especially this is the beginning of the 20th century, this is the time of the late 19th, when travel was developed, quite actively began to develop, when people began to move in space, when they were somewhat, say, softer than the norm to such a concept as prostitution and the spread of sexual infections, gonorrhea and arthritis were huge problems. Well, now it seems like this is not a frequent occurrence. Various metabolic diseases, that is, diseases associated with metabolic disorders, for example, gout, yes, associated with impaired uric acid metabolism. This is hemochromatosis, Wilson's disease. With all the desire, all this leads to the fact that there is a violation of metabolism in the area of cartilage tissue. For example, even with the same gout, there may even be a loss of uric acid crystals, which mechanically even damage our cartilage tissue. In the final, we have the subsequent development of osteoarthritis. Age, heredity. Here the connection can be traced purely statistically, but in fact there is a connection. With age, the number of, say, patients with osteoarthritis increases dramatically. Therefore, a lot of osteoarthritis is referred to by such a term as the natural physiological aging of our joint apparatus. That is, if we take the articular apparatus and roughly present it as a mechanism, then this is the aging of the mechanism of our articular apparatus. The variant of menopause in women, which often lead to serious hormonal changes in the body, quite often contribute to and provoke the appearance of signs of osteoarthritis at this age, namely in women. Genetic factors. Well, it's a rarer thing. This is a mutation of the collagen gene of the second type, this is Stickler syndrome, these are hereditary household bones and joints, this is ethnic, oddly enough, belonging. The Negroid race is more prone to developing osteoarthritis. Well, there is such a feature. Hereditary predisposition. It was also noted that hypoden nodules are much more common in mothers and 3 times more common in sisters with osteoarthritis. Just a few words about the pathogenesis of osteoarthritis. Deforming osteoarthritis is an irreversible process, the disease is chronic. As such, recovery in this case is not planned and the disease can only progress. The progression of the disease depends on the initial trophism of the articular tissue, that is, on violations of regional blood flow in the joints, on areology, that is, on various variants of microthrombosis, on the severity of capillary insufficiency, especially in the subchondral zone of the bone. This is one of the leading factors, because the cartilage does not have its own vascular bed, meaning mature cartilage of an adult organism and feeds either by diffusion from the underlying bone tissue or the spinal fluid. Osteoarthritis is based on quantitative and qualitative changes in protogiants, this is the main active cartilage, as well as damage to chondrocytes. That is, our dystrophic process associated with a violation of the nutrition of this zone leads to damage, say, to a violation of the nutrition of chondrocytes, to damage them, as a consequence, to a violation of the anabolic processes of proteoglycan production, to the prevalence of catabolic processes, that is, the destruction of these very proteoglycans. Here aglycans, especially damaged, partially destroyed, have sufficiently antigenic properties. As a consequence, an autoimmune process cannot be excluded, that is, they can serve as a source of an autoimmune reaction. A decrease in the content of ducts is one of the manifestations of cartilage degeneration. Cartilage degeneration, death of chondrocytes, is a direct road to the activation of the phagocytosis mechanism. That is, the products of degeneration should be, let's say, destroyed, that is, they will undergo phagocytosis. In the process, there is also the death of the phagocytes themselves and, as a result, all this is accompanied by the same inflammatory reaction. Therefore, some were the thought of foreign medical, say, scientists that it is more correct to call the osatric process can and has the right to exist. That is, the whole thing leads to an inflammatory reaction, to the proliferation, let's say, of the inflammatory component of our leukocyte germ, which rushes into this zone of phagocyte proliferation, and to the phenomenon of secondary synovitis, which is most vividly and colorfully manifested in the form of edema in the joint area, in the form of an increase in the pain component. Yes, the development is directly the most deforming osteoarthritis clinic prognosis. The prognosis of deforming osteoarthritis is slow. This is a slow chronic process, but with an irreversible increase in symptoms. Due to the slow dynamics, the ability to work of patients is preserved for a long time. That is, the exception is the hip joint. The joint, which even, as we say, in terms of gravity has a very powerful physical impact. Here is coxarthrosis. This is the disease called coxarthrosis, osteoarthritis of the hip joints, which quickly turns into a state of decompensation. All other joints are rather, say, relatively slowly destroyed, and the rate of reduction of the articular gap, for example, with gonarthrosis, that is, with osteoarthritis of the knees of joints that experience no less load, but it is much larger in area in terms of contact, and the specific pressure on the cartilage tissue is less here. So the rate of reduction of the articular thickness of the articular gap is quite moderate here. It is 0.3 mm per year. Of course, I would like this process to completely stop, but if the disease has started, then progress is inevitable, progress of a negative nature. There is deforming osteoarthritis with very rapid bone statutory destruction. This is the same erosive osteoarthritis against the background of genetic inferiority. This is the field of osteoarthritis in menopausal women. This is osteoarthritis, combined with endocrine disorders, in particular with the phenomena of obesity, that is, with the phenomena of rapid weight gain. So, let's talk about the osteoarthritis clinic. The main complaint, yes, is that the symptoms that the patient describes with osteoarthritis are a complaint of pain. The progression of osteoarthritis, chronic pain, and reflex muscle spasm leads to the formation of tendon muscle contractures. Variants of pain syndrome, but here the pain is absolutely diverse. You remember, when we discuss writing student case histories in practical classes, we pay quite a lot of attention to various characteristics of pain. Let's talk about the variants of pain syndrome in chronic disease, deforming osteoarthritis. So, pain has a mechanical rhythm. This is due to a decrease in the cushioning capacity of the cartilage. That is, joint pain worries when moving and increases in the evening, that is, after a day's, let's say, workload. It weakens at rest and often subsides after a night's sleep. Perhaps a slight morning stiffness. This is a sign of the presence of inflammation. It does not last long, less than 30 minutes, and this is how it differs from a longer morning tendency in terms of differential diagnosis with rheumatoid arthritis. The next variant of pain that may be present is the starting pain. The starting pain occurs briefly in the first 15 to 20 minutes after the start of the movement. It is caused by the friction of the articular surfaces on which pieces of destroyed cartilage have settled, or pieces of bone matter if the destruction has reached so deep that the cartilage has completely destroyed. With further walking, the pain usually subsides, but it can resume with prolonged increased stress on the diseased joint. The next type of pain in deforming osteoarthritis is temporary. Constant pain may be associated with reflex spasm of nearby muscles, with the presence of tendon muscle contractures, yes, with fibrosis of the articular capsule, as well as with the development of reactive synovitis and neuropathy. Note that now there are approximately similar pathological processes that we discussed with you at the last lecture, when we condemned osteochondrosis. That is, it is a spasm of the proper muscles, it is a neuropathy that occurs in this case. Hence the conclusion in the process of complex treatment of, let's say, osteoarthritis, it is very similar and intersects with the complex treatment of osteochondrosis. And we should not forget in this case about the group of drugs that we discussed at the last lecture. This is about preparations of vitamin lot B, that is, these are drugs that improve nervous trophism, and also about weak muscle relaxants. They will definitely have a positive effect in terms of treatment here, too. Well, as a consequence of constant pain, this is an inflammatory process, and here, of course, the main, say, application in terms of treatment, we will give preference to this non-steroidal anti-inflammatory agent. We'll talk about the treatment later. Nocturnal pains that can bother a person with deforming osteoarthritis are mainly caused by venous stagnation, an increase in intravenous venous pressure. Usually these are ischemic disorders, and in this case, if we look at X-rays of such patients, we often will not be able to note any pronounced manifestations of deformity, that is, deforming osteoarthritis, that is, in those very osteophytes. But the pain in such people is usually the initial stage of the process, can disturb a person at night. Pain in a certain position or with certain movements. It occurs when the capsule is stretched, when the periarticular tissues are affected, that is, when in this case there is a phenomenon of periarthritis. Sudden pain in osteoarthritis can occur unexpectedly, abruptly, for example, when walking. And this may be caused by a blockage of the joint or the presence of an intra-articular chondromatous body. That is, a free-form body is a fragment of cartilage that broke off at the front of a degenerative dystrophic process and, roughly speaking, it is quite large, which goes into free, say, swimming inside the joint. Such a thing is sometimes called a joint mouse, so this articular mouse can actually cause mechanical blocks in the joint, that is, not to bend or straighten, that is, some amount of movement in full, jam the joint. Naturally, this is accompanied by a very sharp momentary pain. In addition, sharp pain can be caused by the introduction of osteophyte into soft tissues, that is, some kind of uncomfortable movement and the joint is deformed. We have growths that can, in this case, carry out a mechanical effect on the nearby part of the joint capsule. About capsules, if you remember, very well nervous. This can cause a sharp sudden pain. So these are exactly the characteristics of pain found in deforming osteoarthritis. Let's talk about our physical examination, because, of course, we talked about the symptoms of pain. You understand perfectly well that this pain will affect the function of our musculoskeletal system, and there may be complaints about a violation of this function, but it is possible to identify all this by physical examination. So, we collect information about pain, fix it. Pain is fixed with passive-active movements. This is one of the manifestations of osteoarthritis. Therefore, in addition to pain during movements, we can hear a crunch, hear crepitation. This can definitely be, let's say, enhanced by ausculting the joint zone when performing passive and active movements, but often this crunch can be heard and banal just by the ear, and we can feel it during the palpation of the joint by asking a person to start performing a movement or by performing passive movements ourselves. The next option, on examination, we can definitely see the deformity of the joints. Yes, the initial stages. Often, the deformation can be associated with swelling in the area of the joints, but in the subsequent stages, in the process of proliferation of bone formations of these same osteophytes, in the process of deformation of the underlying bone tissue, defiguration and deformity of the joints are very striking. And often the deformation is so pronounced that we see the curvature directly even of the axis of the limb. The decrease in the amplitude of movements is also noticeable. Remember, in the process of writing your medical history, I gave you methodical instructions. There is one interesting section when we describe musculoskeletal devices, the so-called orthopedic status. And in the scope of the metal accompaniment of this section of writing history, you were offered, let's say, normal indicators of movement in the joints and indicators that can be counted as a violation of function. In this lecture, we will repeat this point with you once again and you will understand that, in principle, the function of movement in the joints, that is, this volume can be assessed, and as a result of this very assessment, we can talk about a violation of this function. As a consequence of movement in the joints in the final, it can affect a violation of the function of walking, a violation of the function of standing, and if you take it with the upper limb, it can affect a violation of the function of grasping, holding, as well as a violation of the labor function in a person. Just about the deformity of the limb to their fullest extent. Valgus medial, valgus lateral, or varus medial under dislocations of joints. There are fill stages of deforming osteoarthritis, and this has to do with the lower extremities and visually, in particular, gonarthrosis. We can even see from afar how a person approaches you, already initially declare that we are dealing with a deformity of the musculoskeletal system. In the presence of synovitis, when the process passes into the stage of inflammatory, yes, the body's response to the destruction of cartilage, the joint may be enlarged as a result of swelling, it may be swollen, it may be quite painful. It is not locally painful in the area of attachment of tendon-connected components, in the area of attachment of the joint, namely, flying palpatory soreness in the area of the entire joint. Plus, we can detect such a manifestation of the inflammatory process as an increase in local temperature precisely with blueness. In addition, if we, for example, palpate such a large joint as the knee prints of knee joint synovitis, we can disrupt the presence of fluid inside the joint, that is, a specific symptom of balloting. The symptom is characteristic of hydroarthrosis of the knee joint. The presence of synovitis and hydroarthrosis of other joints can be assumed by the protrusion of zones to some extent, by the defiguration of the joint zone. Additional research methods. The main instrumental method of investigation in this case is X-ray examination. That is, a reliable diagnosis of osteoarthritis is impossible without radiography, although the severity of mediological changes does not always correspond to the clinical picture of the process, does not always correspond to the severity of the disease. But at the same time, we have radiological signs that underlie the stage classification of the process. This is one of the few cases when we will talk about it at the next SVADA about the X-ray clinical classification of our pathological process with you. Let's talk a few words about what we can find with you on the X-ray picture, on the X-ray of their joints. So, the first sign is an asymmetric narrowing of the articular gap due to the disappearance of this very cartilage. That is, the degenerative process leads to the fact that the articular cartilage is destroyed, it decreases in its thickness. And for example, pay attention to the left snapshot. This may not be very high quality, but it is a snapshot of a deformed knee joint, and note that there is practically no articular joint on the inside. From the outside, that is, you and I have a relatively certain width of the articular gap, where articular cartilage may still be preserved, and from the medial side we practically lack cartilage. Of course, this is a running process, but we are talking about the fact that the narrowing of the articular gap in osteoarthritis is about 0 to 3 mm per year. It is important to evaluate this in terms of radiological indicators. Subchondral osteosclerosis. Pay attention, here in the same area where there is practically no cartilage, in the left picture we see a very bright white glow, let's say, which is noted precisely in the subchondral zone of the bone. Approximately the same in the right picture, where there is practically no articular gap and very, let's say, clearly we find the bone. That is, we can assume that there is an extremely dense bone here. It is sclerosed, it is falsified. As a consequence, since it is so sclerosed, it no longer has a spongy structure, but such a monolithic calcified structure. As a result, it means that there is less and less bloodstream in it, that is, blood vessels that are abundant in the spongy bone. And since it does not have such a bright and powerful bloodstream, it means that we do not have to say that we have a high-quality blood supply to the very cartilage that lies above this very subchondral bone. Subchondral cysts, yes, the latter arise as a result of the transfer of load from cartilage to bone. In advanced cases of osteoarthritis, we find the situation that the cushioning function of such a soft formation as cartilage is absent. The load begins to fall on the bone. The bone, in this case, experiencing mechanical effects and at the same time, definitely being already in a state of itself, say, dystrophic state, when, due to the fact that the bone has been sclerosed, it is poorly supplied with blood, nourished, local areas of necrosis may begin to form in this zone and in the subchondral space may be detected on agenography, and better not on this, on high quality, on digital geography, areas of bone matter discharge which is called subchondral cysts. They are even more qualitatively visible on computed tomography when it is performed and, in principle, can be detected when performing magnetic resonance imaging, but here, with BRT, of course, we pay more attention to, say, the soft tissue structure, namely the thickness of the cartilage. Here it is very qualitatively visible, its refinement. Well, let's go back to the traditional radiological information, to radiography. The third manifestation, quite clearly overgrowing everyone's eyes, are the marginal bone growths, which are called osteophytes, and the process of osteophytosis itself. Yes, when we, here, pay attention, here in the left picture, especially from the most severely affected ideal side, are very clearly visible, especially on the shin bone, more powerful osteophytic bone overgrowth with a pointed end. For deforming osteoarthritis, atypical detection during X-ray examination near compound osteoporosis. On the contrary, we are talking about compaction of the bone substance, sclerosis, yes, and local, say, areas with impaired density will pour out not in the form of total osteoporosis, but in the form of our subchondral cysts. There may be subchondral rounded cysts themselves, and in contrast, this is different from rheumatoid arthritis. The fabric is compacted around them, it has clear contours. Hidden cysts in the joint cavity, that is, they sometimes open these cysts into the joint cavity, leading to partial destruction of the closure bone plate. Yes, sometimes these cysts communicate with the joint cavity. Other methods of additional research. Let's talk about a laboratory study. Systemic manifestations of arthrosis are absent. That is, in essence, with classical osteoarthritis, performing laboratory tests, for example, of blood, in most cases we do not notice any changes. In the presence of an inflammatory component, in the presence of synovitis, the participation of patients may slightly show signs of inflammation. That is, soy may increase, sometimes reactive protein may increase. Although in most cases, the TSE reactive protein acts most of all arthritic, but as that is, let's say about rheumatoid arthritis, that is, in such diseases. I have already said that the tomographic method of investigation gives us a fairly high-quality picture. These are magnetic resonance imaging and computed tomography. There are quite modern techniques that allow you to contrast well and distinguish soft tissues. This makes it possible for us to clearly measure the height of the cartilage, and in the dynamics of doing this, because we still have a chronic process from year to year, we can track, say, the rate of negative changes in the speed of dynamics, or vice versa, the option when the process stops. Another method of extremely high-quality diagnosis of osteoarthritis is arthroscopy. The method of early diagnosis is especially indicated when there is a discrepancy between complaints and the X-ray picture. Yes, the method is invasive, yes, it is inaccessible, because after all, it is not exclusively stationary conditions. That is, in the case when we find a pronounced clinical picture that is not confirmed to us by the methods of radiation diagnostics, it is quite possible that arthroscopy will give us a more complete answer. In addition, the method can perform not only diagnostic, but also therapeutic functions in the case of the very phenomenon that was described when we are dealing with joint blocks, when we assume a variant of chondromatous bodies, especially if they are confirmed on MRI when we have articular ears. The same thing, this method allows you to perform a cartilage biopsy, and as a result, to conduct its morphological examination. Osteoscintigraphy method is an interesting method that is quite highly specialized, mainly used in onco-orthopedics and not widely used, but the method is radiological using radiological radiopharmaceuticals and, accordingly, with the subsequent location of the accumulation of these drugs using a gamma camera. The ultrasonic method of blindness is very widespread, not expensive, but not to say that it has found a very wide application. That is, we can somehow assume, say, the option of using this technique only for large joints, shoulder, knee, and hip. Please note that a rather interesting sign is presented on the distant matchmaker. It is foreign, not new, already from the 64th year applied in America. We have also had it since the Soviet times, since the 84th, but the essence of this approach is a point system, in which a certain manifestation of osteoarthritis has its own number of points, and as a result, we determine the sum of points, respectively. We do not have osteoarthritis, it is probable, or already confirmed, or, so to speak, as they say, a certain osteoarthritis. In fact, this is more for, let's say, your general understanding of this process, and I don't think it is widely used in the clinic. But this classification is very widely used in the clinic. This is the so-called clinic X-ray classification of the stages of osteoarthritis. I already mentioned a few swipes ago that there is a very interesting approach here, in which the clinical picture is linked to the manifestations in the instrumental method of diagnosis during X-ray examination. And as a result, the osteoarthritis disease itself undergoes a stage consisting of 3 stages. The first stage. What do we find here? This is a minor limitation of movements in terms of our assessment of physical. The instrumental assessment is a slight uneven narrowing of the articular gap, slight sharpening of the edges of the articular surfaces, that is, osteophytes are just beginning to form. The second clinic is the oncological stage of osteoarthritis. This limitation of mobility in the joint has already sufficiently declared itself. This is a pronounced narrowing of the articular gap. This is when evaluating movements, a rough crunch is detected during movement. Once again, it probably slipped through again that on radiography there is a pronounced narrowing of the articular gap, significant osteophytes appear, phenomena of subchondral osteosclerosis appear, and if it is impossible, especially when using digital radiography, we can note cyst-like enlightenment in the epiphyses. The third stage of osteoarthritis is a deformity of the joint, which is already really visible when examining patients. This is a sharp restriction of joint mobility. During the X-ray examination, we note deformation and compaction of the articular surfaces of the epiphyses, extensive osteophytes, areas of necrotized bone tissue. It is quite possible up to directly even on the X-ray examination of the identified articular mice. Subchondral cysts. Here is a classification that divides into 3 stages of the course of the osteoarthritis process. It is also customary to divide osteoarthritis into 2 large types. This is a primary or so-called idiopathic deforming osteoarthritis. On average 40–50% of cases belong to this type of osteoarthritis. This is a degenerative process that develops on healthy cartilage. On the contrary, for example, under the influence of excessive constant physical exertion, microtraumatization, that is, as such a full-fledged one, we will not find a clear tie for some expressed reason here, therefore this form is called idiopathic. It is characterized by symmetrical joint damage. Interphalangeal, hip, knee joints are more often affected. There is a vocal lesion of 1 or 2 joints or an inneralized process in which 3 or more joints are involved. Another type of osteoarthritis is a secondary deforming osteoarthritis of 50–60%. Here the degenerative process develops already on the altered cartilage. For example, against the background of vascular disorders or developmental disorders, against the background of systemic diseases, such as hemophilia or a disease with the formation of calcifications. For more, probably, say, a clear example of secondary deforming osteoarthritis is osteoarthritis after injuries, in particular, after intra-articular fractures with damage to the integrity of the cartilage itself. Another variant of secondary deformity is its cause is infectious arthritis, a sultry inflammatory process directly in the joint cavity. In cases of secondary deforming osteoarthritis, joint damage is more often asymmetric, yes, one that is not typical for primary osteoarthritis, that is, any one damaged joint is affected, for example, the shoulder, elbow, wrist, that is, on the one hand. The promised table, which allows you and me to assume functional insufficiency that occurred in the joint against the background of the process, that is, our pathological osteoarthritis. Then note that there are normal indicators characteristic of each of the joints. Here is listed the moment of the various movement options available in this joint. Well, let's use the example of the shoulder joint flexion, extension, retraction, rotation to the outside, rotation to the inside, and, accordingly, 3 degrees of restrictions are mild, moderate and pronounced, that is, a violation of the function of the joint of the 1st, 2nd or 3rd degree. Having evaluated the movement with the help of orthopedic compasses, you and I can clearly say to what extent we have limited functionality, that is, the functional capabilities of the joint. Hence, by adding up these several types of classifications, we can correctly formulate and correctly diagnose. That is, the diagnosis should contain an indication of the form of osteoarthritis, primary or secondary, respectively, naturally, with the name of the joints interested in this pathological process. If there is an INVIT, instructions are necessarily made that we are currently in a state where synovitis is present. The clinic, the radiological stage of the process is indicated and the degree of dysfunction of the joint is indicated. An example is secondary post-traumatic deforming arthrosis of the right knee joint. The second stage is functional insufficiency of the 1st degree. I mean, what can we say? The first thing was that there was an injury. Please note, yes, that we have deforming osteoarthritis of the right knee joint. You will find, you see, still slightly, that is, on the one hand significantly, on the other less pronounced narrowing of the gap. Yes, that is, we have the second stage with osteophytes. Yes, and when evaluating movements, namely the angles of flexion extension in the knee joint, we will find the first degree of violation. The main clinical forms of osteoarthritis, that is, which joints are most often involved in this case and which types, say, or forms of osteoarthritis are most often treated, most often, say, people get sick with them. Here, pay attention, we will now try to disassemble the deforming osteoarthritis of the hip joint, which has its own name, arthrosis, deforming arthrosis of the knee joint, actually called gonarthrosis, deforming osteoarthritis plus not the phalanx of the thumb, and there is such a thing as osteoarthritis field. Coxarthrosis is a symptom of a more mechanical nature in the hip joint. Occur when walking, most often at rest subside. At the beginning of the disease, the pain is localized. It may not necessarily be localized only in the joint of the knee, hip joint. She can hurt in the knee, in the groin, in the buttock, in the lower back. And at the same time, in this case, at the initial stages, we may not detect obvious signs of osteoarthritis on the X-ray. Most often, the cause here is a reflex spasm, and in this case one of the components of treatment, such as myorexins, which we discussed at the last lecture, is sit-out. Midocal provides very effective treatment in this case. Although deforming osteoarthritis is characterized by less restriction of the volume of movement than with arthritis, it is coxarthrosis that is an exception. With osteoarthritis of the hip joint, the volume of movements decreases very early. Coxarthrosis in its expanded stage is characterized by atrophy of the muscles in the hip joint, often forced position of the limb, compensatory lumbar hypobosis, pelvic tilt towards the diseased joint, which leads to impaired posture, impaired walking, which leads to chronic pain syndrome, except in the area of the hip joint, also in the back and lower back. And as a consequence, if this patient has osteochondrosis, most often these diseases go in pairs, then, accordingly, he still suffers from the phenomenon of osteochondrosis. A patient with coxarthrosis has a change in gait, the patient limps on the patient's leg, and with a bilateral lesion of the hip joints, the so-called duck gait develops, that is, a waddling of the trunk. With the onset of complete loss of joint mobility, most often more disappear, right? And, accordingly, there, you understand, very much suffers in this case, the function of moving in space. Ankylosis of one hip joint causes disability as a percentage, if expressed 50 to 70%. That is, the person in this case is disabled. Bilateral ankylosis leads to complete disability, a person is completely deprived of the functions to move. Pay attention to the instrumental diagnosis of coxarthrosis. X-ray examinations show a narrowing of the articular gap on the medial side. If there is no narrowing, but there is pain in the joint, then most likely it can be reactive bursitis. There is such a form of inflammation, especially if we have a pain syndrome in the hip joint at a fairly young age. We also note the classic manifestations of osteoarthritis. This is osteosclerosis in the subchondral region. This is the appearance of osteophytes, well, especially in the area of the roof of the acetabulum. Cyst-like rearrangement and enlightenment with clear contours in the area of the head of the hip bone. One of the characteristic manifestations of osteoarthritis of the hip joint. Please, in this case, carry out a clear diagnosis with metastasis of tumors in this area. The bone is compacted in the area of the femoral head, and there are possible variants of its dislocation, that is, it is asymmetrically located by the femoral head in relation directly to the central one, that is, to the center of the iris. To diagnose coxarthrosis, it is necessary to have pain in the hip joint, as we, remember, said, the main symptom of this disease. Pain can be combined with any two of the following symptoms. That is, one of them is the absence of signs of infectious inflammation, that is, we have our own less than 20 mm per hour. These are radiologically detectable osteophytes of the femoral head or acetabulum. Or the third is an endologically detectable narrowing of the articular gap in the upper and medial part of it. Under the word axial in this case, the oblique direction rises, that is, the upper medial direction. The next common, say, type of osteoarthritis is the so-called gonarthrosis. This is hip arthrosis. It is also more mechanical in nature, occurs when walking, the pain passes at rest. The pain is usually localized along the anterior or inner surface of the joint and there is a so-called feeling of legs giving way. That is, it is not a person who says that he walks uncertainly, he has an uncertain gait, he is afraid of falling precisely because of the fact that this pain appears. With palpation, a local disease may be noted due to the compaction of the bags of the knee joint. There is often atrophy of the thigh muscles. This is especially noticeable if we have secondary gonarthrosis, when we do not have a symmetrical joint lesion. At 50%, we begin to notice a deformation of the axis of the lower limb after some time. That is, there is a deviation and deviation of the lower leg and, accordingly, X-shaped or Y-shaped deformation of the lower limb. During the X-ray examination, it is necessary to indicate that not only classical front projections are performed, that is, anterior-posterior, or sometimes it is called FARS, well, by analogy with banal photography. And the lateral one, which, for example, is also called lateral or sometimes called in profile. Yes, but also the third projection, that is, which is aimed at assessing the state of the patelles and the moral joint. That is, let's say, the articulation of the patella and the distal epiphysis of the femur. That is, when performed on a bent knee joint at an angle of 60 degrees from the upper edge of the patella. That is, the potifemoral joint or knee femoral, as it can be called in Russian. In this case, when evaluating it, we note the isolation of the narrowing of this articular gap between the knee and hip. That's what the third projection is for. To diagnose gonarthrosis, it is necessary to exclude a number of diseases, in particular such not the most frequent, but still diseases as ischemic bone necrosis is a bone disease of the budget, hypercalcinosis is pyrophosphate arthropathy, that is, it is a metabolic disorder, hemochromatosis, chronosis, hemophilia, inflammatory processes in the joint, that is, arthritis. That is, most often it is of an infectious nature, including a specific infection such as tuberculosis. There is also the concept of neuroarthropathy, the so-called Charcot joint or hemochromatosis. There is also a disease in which cartilage is destroyed and chondromatous bodies appear inside, directly along the joint. The three following criteria for gonarthrosis are limitation or soreness with passive flexion of the knee joint. That is, normally, flexion should be at least 135 degrees, and extension, respectively, to 0. The norm is when the limb is even. The next manifestation is osteophytes. Osteophytes or subchondral sclerosis. Also the appearance of subchondral cysts. That is, we have already talked about all these manifestations. Well, the third option of the obligatory, say, manifestation of gonarthrosis is a narrowing of the gap of the same patellofemoral joint, that is, the femoral generational joint, and also makes up the gap between the femoral and tibial joints, that is, what we traditionally see on the X-ray as the knee joint. What complications can there be from gonarthrosis? One of the most frequent complications, and with us, if you remember, the knee joint is the largest joint in the body. This is secondary reactive synovitis. That is, there is a lunge into the genital joints, an inflammatory attack. This may be accompanied by an increase in temperature on the inner surface of the joint, that is, vocal hypothermia, pain increases unambiguously at this moment and the joint flows away, a clear swelling appears, but even with bulging areas, that is, when we can even try to assume that there is fluid inside the joint. palpatory. Accordingly, we can determine the symptom of balloting with a large volume of synovial lunge, although with a small volume such a thing is not confirmed. And sometimes articular blocks may appear, that is, when the joint gets stuck in one of the positions and the patient cannot fully stretch the knee joint to the end, for example. Uterine necrosis of the femoral condyle with the separation of the bone segment in femoral tibial necrosis most often leads to this when we have an articular mouse that jams the knee joint. It can manifest itself externally under the dislocation of the patella, when it is constantly in this state on the knees. Well, there are variants of spontaneous hemorrhoids, when the patient on the one hand does not note any pronounced trauma or bruises of the knee joint anywhere in the anamnesis. And at the same time, our feeling when we assess the situation with the joint is hydroarthrosis. We do the function, we note not just synitis, that is, we will have a yellow cloudy fluid at the puncture, but hemorrhoids. Another of the manifestations, that is, one more of the forms of frequently encountered osteoarthritis is deforming osteoarthritis of the first plus non-phalangeal joint of the foot. Usually this process is two-way. The pain is more often localized along the inner edge of the foot. This form of deforming osteoarthritis is often inextricably linked with such a well-known orthopedic form of foot deformity as hallux valgus. This is a hallux valgus deformity of the big toe. Most often, valgus deformity of the big toe occurs in women. Statistics note that for one man suffering from such a form of deformation, in which just one of the manifestations is arthrosis of the first composition of the toe phalangeal joint, there are 10 women. This may be due to the genetic or anatomical predisposition of women to develop this condition. For a long time it was believed that one of the main reasons for such a sexual differentiation, a disease, is the style of shoes that women have. These are shoes with narrow socks and high heels. But at the moment, if we consider medical statistics, there are already quite a lot of studies that a new generation of women who have grown up has a fairly large volume, which in principle did not wear narrow shoes with high heels. That is, well, roughly speaking, now the current youth is switching to a more physiological and calm form of shoes, that is, sneakers. But at the same time, they also have such a disease as hallux valgus, and it is accompanied by arthrosis of the first plus non-phalangeal joint. Yes, indeed, probably, the frequency of occurrence will be lower. The investigation is not fully completed, but still this disease is present and only with the shape of shoes it connects, probably, is not authorized. Secondary deforming osteoarthritis plus not the phalanx of the big toe can often develop with such a systemic disease as gout. And it is definitely worth differentiating these types of pathology. Another form of manifestation, not the most frequent, probably, well, the most rare of these four is polyosteoarthritis or the so-called arthrotic disease. A variant of deforming osteoarthritis with multiple lesions of the peripheral joints up to the lesion of the intervertebral joints. It can be primary and secondary. And mainly, it occurs against the background of metabolic arthritis. These are gouty arthritis, perfosfate apathy, achronosis. The primary field is osteoarthritis, but also with the name Kilgren's disease. It was described in 1952 by the English scientist Kilgren and Moore. The lesion is usually symmetrical and is based on generalized chondropathy plus weakness of the ligamentous apparatus. Among the manifestations is a lesion as well as joints. This is intervertebral cartilage, that is, the disc dig is a multiple lesion of the tendon in the area of their attachment, bone, which manifests itself by the formation of an asphyxiating ligamentosis, that is, such bone outgrowths begin to form in different places. This is a generalized joint lesion, most often bilateral, symmetrically, and large joints suffer. The knee is slow and small interphalangeal. And the phenomenon of periarthritis and tender vaginitis. Well, I have already said about ligamentosis or gemontitis. Let's talk about the treatment of osteoarthritis. There are quite a lot of treatment options. Many specialists are involved in this case as therapeutic specialists, and osteoarthritis is, as we have already said, the most common of non-communicable diseases, one of the most frequent, so this is a fairly large volume of patients who turn to a local therapist. In addition, orthopedic traumatologists are engaged in this, various rehabilitologists are engaged in this. In principle, a large amount of sanatorium resort assistance is provided to people with such pathology of the musculoskeletal system. What does treatment include? Non-drug treatment may be used here, that is, we will talk about it now. Medicines were used. A rather interesting group of drugs about the technique is the use of synovial fluid prostheses. On the one hand, this is an invasive measure when the injection is performed into the joint cavity, and at the same time, in essence, it is still a conservative technique. So something in between, yes, on the borderline between surgery and therapy. And, accordingly, surgical treatment. We will also talk about him today. Plus, I will tell you about some modern methods that may not be very widespread yet, perhaps they are still being challenged statistically as effective methods, and maybe their, let's say, ineffectiveness of using as therapeutic methods will be proved. Well, to say that they are, after all, we will need to. So, not medical treatment. Most often, physiotherapists and so-called physical therapy doctors, or, as they say now, kinesiotherapists, are engaged in this type of treatment. What can be included here? This is joint gymnastics in the scope of physical therapy. Physical therapy in this case strengthens the muscles, prevents their atrophy, helps to relieve pain. Yes, sometimes the moment of physical therapy is clearly connected with the work of a kinesiotherapist. Yes, that is, and in this case it is called kinesiotherapy. In parallel with this, the so-called post-isometric relaxation is performed, when the patient is placed in a certain position, that is, he is taught to relax the muscles and at the same time the right to strain it correctly during this very exercise. Massages. Massage in this case is quite a useful thing, but at the same time it must be understood that only a period can be used, let's say, outside the period of exacerbation of the process. The basic principles of physical therapy for deforming osteoarthritis are not intensive movements, careful, gradual. That is, movements that will constantly cause pain, they are contraindicated. In this case, when the pain increases during physical exercises, either the exercises are changed or the intensity of these exercises is reduced. At the moment of exacerbation, on the contrary, unloading of the burnt joint is necessary, that is, complete rest. If you and I are still engaged in this kind of physical activity, walking, it should alternate with rest. With synovitis, if a person walks, additional means of movement can be used for him, that is, a cane is used. In this case, long-term load is not recommended, that is, long-term static in the form of a long state, or long-term dynamic. It's not worth walking for a long time. In order to relieve the joints, such a form of physical therapy as swimming is highly recommended. It is permissible to ride a bicycle or an exercise bike, but it is desirable to limit running. At the same time, when assessing, say, a person's ability to engage in physical therapy, it is very important to treat the patient's shoes, because often they can use the wrong shoes and in the end, let's say, any activities can even cause harm. Well, usually here I am for the elderly, whom they have a great difficulty in constantly performing some obviously interesting various forms of physical activity. Yes, that is, in this case, I usually recommend banal walking on flat terrain to them, so that this thing is, let's say, permanent and systematic. They need to prescribe a dog. Yes, a banal little dog, sometimes two. That is, for example, if you don't walk a dog a day, she will, poop on you. As a result, no one wants it, so the dog needs to be walked. The dog does not do his business right away. Therefore, a small dog, well, at least half a kilometer to go, so that, she made her physical departures. After that, accordingly, you will walk half a kilometer twice a day. On flat terrain, a small dog does not often climb into all sorts of different rough terrain, ditches and everything else. That is, such a relaxed form of physical activity is enough. It is necessary to avoid hypothermia. In addition to physical therapy, physiotherapy techniques have a fairly high-quality effect. It should be understood here that some of them are contraindicated in concomitant pathology, but still osteoarthritis is most often a disease of the elderly, so it is necessary to approach with caution. From physiotherapy, magnetotherapy is highly recommended. If it is possible to apply electrotherapy options, then you can use sinusoidally modulated currents of SMT therapy, you can use DDT therapy. Phonophoresis with hydrocortisone. This is probably the final form of physiotherapy when we use such a powerful anti-inflammatory drug as hydrocortisone. Applications of biscophyte, sarcurite, paraffin, that is, most often these are thermal procedures. They have a very good effect, but it must be understood that they cannot be used for synovitis. The second part of our therapeutic, let's say, effects on this disease is drug treatment. Here in the treatment of osteoarthritis, it is customary to distinguish two groups of drugs that are mandatory for treatment. This is basic therapy, now we will talk about it, and this is the use of steroid anti-inflammatory drugs, analgesics. I also pointed out to you that doctors often prescribe weak muscle relaxants. Sometimes doctors prescribe vitamins of group B, the meaning of their appointment, the forms of reception, we discussed at the last lecture. In a separate form, the treatment of synovitis is isolated. Well, unfortunately, this is one of the forms of complications of osteoarthritis of large joints and they face it. So, basic therapy. What can be applied here? Use preparations of the mucopolysaccharide group. Here, pay attention, there are three representatives in different forms. Yes, there is a form of oral administration, for example, such a well-known drug as Structum C, well, in this case, with its price and with the form of reception. A variant of the injectable form of mucosad. I do not dwell on this in detail. Weddings you can calmly read and calmly take notes of the reception options. Yes, that is, the form. Well, a fairly common form, not always, but, let's say, the effect that turns out to be some kind is chondroxide. When approaching the issue of the use of basic therapy drugs, you should talk very carefully with the doctor. Oh, with a patient. That is, you remember, I have told you more than once that a doctor should be able to speak, to prove, to explain. In this case, it is necessary to explain the following thing to the patient. The drugs of the basic therapy group do not bring relief to the patient. They are not physically directed in any way to the situation that the patient has gone through any symptoms. Symptoms of pain, symptoms that is, swelling and so on. Basic therapy drugs are designed to slow down the destruction of cartilage. That is, to slow down the process of, say, progression of osteoarthritis. That is, in essence, it is the prevention of future deterioration of the situation. Moreover, unfortunately, there are a number of studies that suggest that there is no statistical probability of the positive effect of these drugs. It is possible to understand and approach this formulation in different ways about the use of methods of randomization of medicine and about the effectiveness of these drugs. You can trust those who produce them, researched, applied. You can believe those, say, in a negative way, who say that this is money for nothing. I don't know what exactly can be said here in this case. I use drugs, I prescribe drugs, I actually track patients sometimes, even if it's not a statistically large number. Yes, but I tracked their condition for a long time and I can say that the use of drugs of the basic therapy group, according to my feelings, really slows down the process of cartilage destruction. Another group of drugs of basic therapy are stimulators of proteoglycan synthesis. Well, the most common of, say, drugs in this group is the so-called DONS drug, which is absolutely in various forms, both in tablet forms, and in injectable form, and in such a convenient form as powder, that is, sachet, which should be dissolved in water and drunk. A garden moment, why I sometimes give it to you in a lecture. You should, with all your desire, still understand that you will not always prescribe these drugs to a socially prosperous group of citizens. I say again, osteoarthritis is a disease of the elderly, and with all the desire to assess the financial capabilities of the patient, well, you somehow have to. Because it is possible that you will prescribe a complex treatment consisting of several drugs to the patient. The drugs will be expensive, and this grandmother, having spent money, will still choose the option when she does not buy all the drugs. She will apply them and not tell you about it, partially use the treatment regimen. And believe me, in this case, but our whole idea of complex treatment can go to the smart. Therefore, think about the fact that there are options for the use of generics. Yes, many argue that the effectiveness may be lower, but with all the desire it will be present. That is, there are options for replacing drugs. In addition, now the focus of our pharmaceutical industry on import substitution sometimes leads to the fact that the pricing policy is so positioned that we can meet domestic drugs with a completely humane price. Again, the quality of this drug and its effectiveness with us will not always be regarded as similar to the original imported one. But if there is no other situation, it is better to use this drug. The next group of basic drugs are combined drugs, which, probably, as basic ones, at the moment it makes sense to recommend. Therefore, let's focus on them in more detail. Here are two bright representatives, unfortunately, imported, yes, produced abroad. This is either Arthra or Terraflex. In essence, they are very similar in composition. These are drugs that include hambroitin sulfate, and include easily substituted hydrochloride. That is, if it is logical to take, these are representatives of those groups of drugs that we are considering on the previous two slides. They are used quite conveniently in tablet form. Note to yourself that the reception schemes are very long. And usually if osteoarthritis is already running and its stage is the second, yes, then I recommend 2 courses a year for 3 months. If the stages are only the initial forms of osteoarthritis, you can try it once a year, but with course treatment for at least 3 months. The form of reception and the specific option is when we first use the bolus form, that is, we use an increased dosage for the first 3 weeks and then switch to a maintenance dose. Here is such a variant of reception, but for me it gives the most high-quality result. Once again, I say, clinically, it will not manifest in any way in the patient. Yes, in this case we are talking about the prevention of the subsequent, say, progression of diseases. But the next group of the drug will give us a clear clinical effect. We prescribe non-steroidal anti-inflammatory drugs, which, if you remember, we have different effects of their own, and in our case, of all the effects here, we are interested in this analgesic effect and the effect as an anti-inflammatory drug. That is, the effect on the very biologically active substances released in the zone of our local disease in the zone, which lead exactly, which are mediators of pain, mediators of inflammation. Non-steroidal anti-inflammatory drugs or drugs, that is, SAIDs, have been known for a long time. You have repeatedly analyzed this group on various absolutely, probably, clinical cycles, plus on pharmacology. This is one of the most commonly used drugs in medicine. Well, pay attention, there is a very interesting classification here, yes, for non-steroidal anti-inflammatory drugs with pronounced anti-inflammatory activity. They are divided into certain groups depending on the chemical derivatives. I'm not forcing you to remember, to approach this, but to know that there are pronounced anti-inflammatory drugs. Yes, and pay attention, starting from the most famous, probably the oldest salicylates. If we recall the history of acetylsalicylic acid, that is, aspirin, it has about 5 millennia. Yes, I didn't misspoke, really. That is, if we take history, then there are records, let's say, hieroglyphic in ancient Egypt, which described the recipe for the production of alder. Yes, it is a herbal preparation, which in essence is the prototype of salicylates. Also here you can see here is a fairly well-known group of anti-inflammatory drugs, such as ibuprofen. Why do I focus on it? This is one of the few old drugs that is licensed not only in adult, but also in children's practice. Yes, deforming is not a childhood disease. It should be understood that a number of drugs are licensed, a number of children are not. One of the most famous, probably, in this group of drugs is diclofenac. The fame lies in the fact that diclofenac is a drug from which the usual effect is counted. It is a reference and it is customary to say that other drugs, for example, as anti-inflammatory are more powerful than diclofenac, or less. Analgesic effects and side effects are also counted from it there. That is, a side effect is more common than that of diclofenac, or less common. NSAID preparations with weak anti-inflammatory efficacy are probably less interesting to us here. Please note, yes, that is, one of the most famous here is metamizole. We know it under the name analgin. A drug that has a powerful analgesic effect, but is practically very much devoid of anti-inflammatory effectiveness. It has very low. It is probably not worth using it unambiguously in general, but in particular here. We analyze why in class. Phenacetin, that is, as well as its derivative paracetamol. An excellent antipyretic, but it has a very weak anti-inflammatory effect. Ketorolac, ketorol, yes, a drug that is a wonderful analgesic, but as an anti-inflammatory, and here the inflammatory component is critically important, the drug is weak. What else can be said both in terms of the classification of these drugs? After all, they should be given great attention, and in terms of the selection of drugs, depending on the selectivity with respect to various forms of cyclooxygenase, it is customary to allocate drugs selective with respect to CoA1 and with respect to CoA2, or approximately uniformly inhibiting CoA1, CoA2. In this case, it is critically important. You will understand at the next wedding. Yes, I think you already remember this. Yes, the situation that, depending on the approach to cyclooxygenase, different types of side effects can manifest in our drugs. Ideally, you and I need to choose the drug for use in the patient in such a way that these side effects on him are as small as possible, and that we do not have phenomena in this case. These are probably the main drugs that are currently most often used in our country as a means of treating osteoarthritis. The American rather expensive modern version of the drug Arcoxia. The drug is narrowly selective, that is, highly selective in terms of exposure only to cyclin or 2. The drug is moderately selective. This is the direction of meloxicam. The original drug was quite expensive, not the original variants of the same meloxicam, and others with it have different names, a huge variety. The drug is widely represented in different price groups. The drug is really good, it has earned both the love of patients, and, say, its sales volumes are large and the volume of use is also large. The drug from the nimesulide group is nice. Yes, there is an option of the original Nimesul in powder, in a sachet, expensive, moderately expensive. There is an option for a fairly inexpensive nice, yes, which is widely used in our country. Perhaps he was unfairly persecuted in the world. Well, this is a variant of, say, unfair competition, when labels of a drug that has pronounced hepatotoxicity are attached to it. As a result, according to research, it turned out that all this is not true. The drug is not actually hepatotoxic. And the drug is Voltaren. Remember I told you about diclofenac? It's just him. Yes, Voltaren is its original form of the name when it began to be produced under the company name Advax. To this day, it is still being produced. The drug is probably the most widely used in the world, but a drug with its own characteristics. It is not a selective CoA2 blocker, therefore it acts uniformly on both CoA1 and CoA2 and therefore uniformly has approximately side effects of both groups. He has a very interesting release form. It is not only in tablet form, in injectable form, but also available in the form of suppositories. You remember that this is a very interesting form of application in which the effectiveness is almost equal to the parenteral administration option, and at the same time, well, with all the desire, there is no unpleasant sensation from intramuscular injections. A variant of the selection, that is, the rules for the selection of drugs from the group of nonsteroidal anti-inflammatory drugs. That is, in the absence of the effect of the drug in the case of its use, namely, in the case of using the maximum therapeutic dose, it is impossible to further increase the dose. You should pay attention to this, be sure to explain it to the patient. That is, if the maximum therapeutic dose does not help you, then there is no point in using a double dose. There will be no effect anyway, but what will happen? And the fact that we have side effects will just add up. This threatens the development of complications. Therefore, if a person is in pain and he uses the maximum dose of NSAID as an analgesic, but there is no effect, tell him unequivocally, it is not worth increasing the dose. It's only going to get worse. Then the next option is the unacceptable appointment of 2 or more NSAIDs at the same time. This is strictly prohibited. The effect is positive, the effect is anti-inflammatory or analgesic, which we are interested in, it does not add up and does not add up. But the side effect is unambiguously summed up. And it is necessary to choose a specific non-steroidal anti-inflammatory agent, depending on the risks of developing releases. It is customary to divide into 2 groups, risks from the gastrointestinal tract and risks from the vascular nervous system. That is, the lower the selectivity of the drug in relation to COX-2, the higher the risk of gastrointestinal complications. That is, COX-1 blockers have a clear pronounced gastropathic effect they have. That is, you remember how it happens, because the COX-1 blocker and blocks the production of prostaglandin E in the brain. As a result, there is less impact on the gastric mucosa, less mucus production, and the parietal cells continue to produce acid, and as a result we have a high risk of gastritis, and even worse acute ulcers. Another option, when using selective co-inhibitors too. Very modern, very fashionable medicines now. These are selective drugs. I just told you at the last wedding about acoxia, about a number of meloxicam and radnimesulide, yes, but they have, unfortunately, side effects. They do not work very well on blood clotting. Therefore, if there is a high risk of developing cardiovascular disorders, then in this case it is worth considering that this is a dangerous use of these. Here on this table, approximately, we select the choice of a specific nonsteroidal anti-inflammatory drug, depending on the risks from the release of the gastrointestinal tract. That is, a high risk of gastrointestinal discharge is noted in patients with a history of ulceration, having in the past ulcerative, well-related gastrointestinal bleeding or, God forbid, perforation of the stomach or duodenum due to ulcers. That is, in this case, if people are elderly, they often already take antiplatelet drugs. These people are not recommended to prescribe nonsteroidal anti-inflammatory drugs. In case of extreme necessity, it is possible to prescribe narrowly, that is, highly selective drugs. This is tercoxib, or goals like SIBs. Well, now in this case Celebrex, goals like SIBs are rarely used. These drugs are used more in urology, yes, or you can try to use, say, moderately selective drugs. This is the direction of meloxicam, or the direction of nimesulide, but necessarily in combination with proton pump inhibitors, that is, with omeprazole. Yes, I do not dispute, in most cases we read the instructions from drugs selectively acting on the COX-2 blocker that they do not have a gastropathic effect in therapeutic doses, but in our case, in this case, it is worth using omeprazole anyway. A moderate risk of gastrointestinal complications is associated with age over 65 years, the presence of dyspepsia, the presence of chronic tobacco smoking, yes, infected with Helicobacter pylori, but this is a rather difficult option to understand the presence of all this. Yes, with the constant intake of glucocorticoid drugs. Here the value of selective or highly selective drugs is possible. I will not repeat that this is a case concerning subluxation. Yes, but again preferably with proton pump inhibitors. In the absence of all these factors, we can talk about a low risk of gastrointestinal complications, and it is possible to use any non-steroidal anti-inflammatory drug in therapeutic doses. Another approach option is to choose depending on the presence of risks from the cardiovascular system. That is, there is a high risk of developing cardiovascular pathology in patients with coronary heart disease, with a history of myocardial infarction, with ischemic strokes, with transient ischemic attacks that could be, that is, with the development of chronic heart failure, in patients with type 2 diabetes mellitus, patients with renal insufficiency. In this case, it is inappropriate to prescribe selective CoA2 inhibitors, that is, those drugs that worsen clotting. Yes, that is, which can lead to the development of traumatic complications. It is quite possible that here, on the contrary, it is worth using the old proven, yes, drugs, but under the cover of those very proton pump blockers. Here are the main differences. Yes, a predominantly selective inhibitor. You see, I'm telling you this Arcosia, it's predominantly selective and it's highly selective, and moderately selective. That is, these are mainly Movales and NICE. That is, the meloxicam group, the nimesulide group. Well, probably at the moment the most commonly used drugs are as anti-inflammatory agents in the treatment of our osteoarthritis. At this wedding, you and I have a daily, say, dose of the drug and the price of the drugs. These are the ones we were talking about just now. Well, both Russian-made and original imported drugs. Take a closer look, pay attention to what you can choose. The maximum we can say is that the course admission in this case is not always regulated by some directly defined figures. Most often they start with short courses, yes, that is, 10 days or 14 days. Sometimes it comes to the point that people drink drugs almost for life, because the pain syndrome does not allow them to live qualitatively. The next section of our lecture, which we say describes the treatment of osteoarthritis, is the treatment of the so-called synovitis. As we have already said, one of the complications of the development of osteoarthritis is the occurrence of an aseptic inflammatory process inside the joints, which includes the synovial membrane, joints, that is, synovitis develops with all its manifestations. Yes, with the release, say, with the appearance of exudate, as a consequence, yes, of this very thickening of a large volume of synovial fluid in the joint, with the appearance and intensification of pain, edema, with the appearance of hydroarthrosis. What would you recommend here? The load is definitely fully relieved, that is, rest for the joint is recommended. Sometimes rest even involves the use of additional means of fixing the joint using orthotherapy. Definitely, if at this moment the patient does not use non-steroidal anti-inflammatory drugs, they are prescribed, because we have both inflammation and a clear pain syndrome. Sometimes non-steroidal anti-inflammatory drugs in the final of their use, say, a long course, do not have a pronounced effect. My point is that it is with this form of osteoarthritis that steroid anti-inflammatory drugs are sometimes used. On the one hand, drugs that are guaranteed to have an effect with us. They provide an anti-inflammatory effect, an analgesic effect, but at the same time drugs that have a bad side effect. Drugs of this group worsen the situation with trophic and cartilage, worsen the situation with the progression of degenerative processes. Therefore, on the one hand, we are treating, and this treatment will be symptomatic for us. It can even be assumed that this has a pathogenetic character, but at the same time we make the process of degeneration in the cartilage and underlying bone area progress much faster. What can be attributed here? Starting from the old ancient drugs of a universal injectable nature, this is hydrocortisone. This is a variant of such a more modern cynologist, who resorbed and joints for a relatively long time and worked for a long time, and coming to modern drugs, which are usually two-phase. Yes, here is the reference drug for injectable local hormone therapy with steroid hormones is the drug Diprospan. This is a two-phase salt of steroid preparations, which one of the phases works for the first 3 months, gradually dissolving, performs all its anti-inflammatory effects. Another phase of the drug, another fraction of the drug begins to dissolve only for a period of 3 months. Therefore, the drug is used once for a very long-term effect, and if it is ineffective, its repeated administration for 6 months, not earlier than 6 months, is only possible. Sometimes the drug Diprospan has difficulties with the sale in our country, that is, Roszdravnadze does not always update the license for this drug in a timely manner, and there are difficulties. The beauty of this drug is that it is available in ampoules by the piece, and most often, as I said, we need to use 1 ampoule once every 6 months. Quite a reasonable price he has. You see here he is 215 rubles for an ampoule. The maximum that needs to be said is that the ampoule should be diluted 1:1 with lidocaine, after which it can be used internally articularly, or sometimes they perform a periarticular form of management, they prick the joint. In this case, it is most often characteristic when we have periarthritis. Yes, not cyanite. For Sanita, it is used inside the joint. Its analog is also imported. This is with you and me, in my opinion, the Slovenian firm Kark. This is flosterone. Here, in the absence of Diprospan on sale, my advice is that you can try to look for flosterone if you need this drug. Now let's talk with you about another group of drugs that are used in the treatment of osteoarthritis. The band is quite modern. More and more he finds, let's say, fans, as among doctors. It is definitely effective, but at the same time they have a peculiar, let's say, feature, not cheap drugs. Domestic drugs have already appeared. There was a great hope that after the appearance of domestic drugs, the price for them would decrease and they would be available to a wide range of patients. But it turned out that we find a situation that domestic drugs in most cases are even more expensive than those used, exported, imported from abroad. It is not known why all this is happening, but still. So, this is the so-called synovial fluid prosthesis group. That is, by the name, you probably understand that these are drugs that, in theory, should definitely get there, inside the joint. These are drugs for local injectable intra-articular therapy and drugs that are supposed to replace the synovial fluid there. Medications are derivatives of hyaluronic acid. Yes, it is widely used in cosmetology. It has certain properties. These drugs differ in their composition and in the length of the molecule. Hyaluronic acid in this case, the viscosity of the substance changes along the length of this very molecule. The more viscous the drug, the longer the period of its stay in the joint, the more effective its medicinal properties, that is, the more, say, in the liquid it will be able to bind on itself, on its molecule, and to a greater extent it has the properties of, that is, restored, say, the moment of revitalization. Then there are various injuries filling the uneven already, and the damaged surface of the cartilage provides a high-quality glide from one articular surface in relation to another. After the introduction of the hyaluronic acid preparation into the joint cavity, the activity of the mite cells, chondrocytes, increases, which themselves also begin to actively synthesize hyaluronic acid, which contributes to the restoration of impaired synovial fluid metabolism. After injection of the signal fluid prosthesis, most patients notice improvement already on the 3rd or 4th day after injection. Pain decreases, the volume of movement in the joint increases. The positive effect of the use of hyaluronic acid preparations is a course of injections. If you take drugs with a small molecule length, this is a course of 3-5 injections when using a drug with a small amount of molecules, as I have already said. A long molecule involves the use of a single injection. On the one hand, it may seem that in this case, it is probably more profitable to use a long molecule. But from personal experience I can say the following: it does not always work positively and efficiently. It is necessary to get exactly inside the joint, and in patients, the patient of the application of the molecule is cross-linked, that is, with a long marker, they always tolerate well. Sometimes for the first 2 or 3 days their pain syndrome increases sharply, they complain and many claim that they acted in vain. That is, as such, there is no psychological effect from the use of an expensive advertised quality of the drug here, and many are disappointed in this. Although definitely on the 3rd or 5th day we have an effect, more passes and indeed the whole complex of positive effects begins to manifest itself. In this case, the course reception, whether it's 3 dashes of 5 injections of a short molecule, or 1 injection with a long molecule, yes, stitched, it usually lasts up to 6 months. That is, a long-acting drug by itself, hyaluronic acid itself has a slight anti-inflammatory effect. As I have already said, the drug is injected exclusively into the joint cavity. Here are the most widely presented drugs in our country at the moment. Honestly, the price of that year. I apologize right away, I didn't have enough time to fix it today. Considering that the drugs are imported, taking into account the last 2 months of the growth of the dollar, the price has definitely increased. I'll tell you right away, the old stocks are already running out of the old price. Drugs are rising in price, drugs are getting more expensive. Well, pay attention, on the left is probably the most commonly used drug, Firmatran. This is a Firmatran with an ordinary short molecule. That is, these DOS need 3 dashes of 5. Well, for usually all these drugs are packed into a ready-made plastic polymer syringe. That is, you only need to twist the needle. There is such an interesting shape of the head, where the needle is not inserted. They are wound directly onto the tip of the syringe and, accordingly, a sterile needle is wound and used for intra-articular injection. The Firmatran is available both in this version, and there is also a Firmatran Plus, where the molecule is slightly elongated and 2 such injections are needed. This is a grey package, they are red, and Firmatran C, where the molecule is cross-linked, it is long and such a substance is very thick, it is used once. Well, as you know, the price of the drug is rising. I have already told you about the effectiveness and, say, the feeling of the patient. Here is the drug Duralan, a drug originally produced with a long molecule. This is a British drug, quite really effective and recently somehow not very widely met. It's too much more expensive now at the moment. Cool down, the most affordable in this case of all these drugs, honestly. Applied a lot, but it seems that he is the least effective of them all. Let's talk about one interesting method of treatment which at the moment can still be attributed to the category of know-how. The method is borderline between surgical, which we will continue to consider, and conservative treatment of osteoarthritis, a method, on the one hand, very actively advertised and promoted, on the other hand, similarly scolded and accused of inefficiency. In fact, indeed, to this day there are no full-fledged randomized studies of the effectiveness of this technique. The method is just beginning to spread, let's say, and again, it is possible that it will eventually be, let's say, rejected. But it is there, it is actively used, and many people say that it helps them. The so-called PI therapy, which came to the big orthopedics from cosmetology. The abbreviation PIP came from the words well-rich plasma, that is, from, say, in translation, it is plasma rich in platelets. That is, PIP therapy is for diseases of the musculoskeletal system based on the local administration of plasma enriched with platelets. Such plasma is obtained by means of special centrifugation of blood on certain parameters, and auto blood is taken as the starting material, the patient's own blood. Therefore, in this case, well, it is quite safe in terms of the epidemiology of the application of this technique. Platelets have very interesting properties. These are blood cells with pluripotent, say, their properties. We have heard more than once that after some time they can transform into a cell of a connective tissue row and direction. Yes, plus platelet cells proliferate quite well and, in principle, with all the desire, there is some scientific background in this method. That is, we take blood, we centrifuge it, we separate plasma from red blood cells, from heavy form elements. We take this plasma with a syringe and then inject it. The procedure is, in principle, not for a long time. The volume of blood collected is also small, somewhere in the area of one syringe. The technique is imported, therefore, it is provided with sufficiently high-quality consumables. Both the centrifuge itself is completely small, and very peculiar and interesting syringes that allow you to perform centrifugation right inside yourself, separate one fraction from another, and then inject it. Injections are made into the problem area and, at least, the phenomena of revitalization are marked, which can occur both in cartilage tissue and in other variants of connective tissue. Here in the illustration is a variant of the introduction, well, albeit animated, into the hip joint in order, say, to improve the situation with cocarthrosis. Yes, I'm not saying recovery, I'm talking about the fact that, with all the desire, there should be some positive therapeutic effect, and also an introduction to, you see, in the area of the chest muscle, yes, as a prevention of rupture of this tendon on the chest muscle. You and I are going through impeachment syndrome in class. We are going through a variant of the rotator cuff rupture in the classroom. This is approximately from this series. That is, in fact, its methods are used not only for intra-articular administration, as the treatment of osteoarthritis as one of the components of treatment and the treatment of various other chronic degenerative dystrophic diseases. Well, for a full-fledged, say, course, usually 1 to 3 injections are required. Injections, as in the case with the introduction of a prosthetic phenomeal fluid, are not performed daily, but at intervals of 1 to 2 weeks. Another modern method of treating osteoarthritis is SVF therapy. The method is quite similar to the method of pepitherapy disassembled in the previous one, and its therapy comes from the English word stroma buccal fraction. This is treatment with cells with a stromal vascular fraction obtained from its own autologous adipose tissue. And its own in the cell is injected inside the composition under local anesthesia. Properties of stromal vascular fractions, that is, cells from this fraction. Cells are capable of proliferation, capable of active growth, division, regeneration of damaged cells. That is, in essence, the method is a method of revitalization. They presumably, according to the authors, notice defects in cartilage, bone, muscle, tendon tissue, stimulate the synthesis of collagen and elastin in tissues. The indications for such cell therapy are quite broad. They basically repeat the indications for PERPI therapy. This is deforming osteoarthritis and quite serious of the 2nd and 3rd degree. That is, in particular, the method for coxarthrosis will change very successfully when access to it has become, well, the most probably trouble-free among all the joints of our body. This is a variant of osteoarthritis of the ankle joint, but in this case, again, you understand the situation that osteoarthritis is still quite competitive terms that are used almost equally among themselves. Rheumatoid arthritis, various types of articular cartilage injuries, whether of a domestic or sporting nature. These are degenerative injuries of the menisci, which have been very often called menicopathies lately. A variant of OCHA in bone necrosis, that is, osteonecrosis. Septic necrosis of the femoral head, dissecting osteochondrosis, that is, it is ischemic osteochondropathy. Various variants of cartilage chondration of the 2nd, 3rd and such as advanced 4th degree damage to the cartilaginous part of the patella, intisopathy, that is, picadylitis, tendinitis on the pectoral muscles. That is, the fact that we are often a precursor to the rupture of the rotational cuff. Partial injuries of muscle tissue, various tendon ruptures, and in particular a partial rupture of the rotator cuff itself. It should be understood that the method is quite modern and to a greater extent all the information about it that is now in the literature and on the internet is PR. The PR is clear. It is necessary to approach with a certain degree of skepticism. On the next slide, we will now look at how this technique is performed and analyze the main stages that are shown here on the slide. Once again, I remind you to think about the fact that randomized studies fully confirm such focal statements, which will be voiced by the author of this technique itself. Well, here we need to approach critically again. Although the method does exist, it has already helped many people. Not a cheap procedure. Here I have just looked at the price, somewhere on average about 40,000 rubles, therefore, and this suggests to the mouse that, after all, this is, as it were, nothing personal. SVF therapy is the treatment of cells of the stromal vascular fraction obtained from a person's own adipose tissue.
Such cells are universal precursors of cartilage tissue cells, which means they are able to restore it. The introduction of adipose tissue cells into the joint, for example, with arthrosis, is an alternative to joint replacement surgery, and in some cases allows you to completely avoid it. At the first stage, an anesthetic solution is injected under the skin of the anterior abdominal wall. This allows you to eliminate pain during the procedure, and also leads to swelling of fat cells for their subsequent selection. After 15 to 20 minutes, they proceed to the second stage, the collection of adipose tissue. The total amount does not exceed 30 to 50 milliliters. The resulting adipose tissue is centrifuged, filtered, cleaned of unnecessary cells, and finally mixed with the patient's own plasma. Plasma is a breeding ground for new cells. After careful mixing, the resulting biopreparation is injected into the joint cavity. Indications for cell therapy are degenerative diseases with cartilage installations, osteoarthritis, degenerative meniscal lesions, osteoarthritis, osteochondritis, control of the second, third, fourth stages. With VF therapy is carried out on an outpatient basis, does not require hospitalization. Takes no more than 60 minutes in time. After the procedure, the patient remains in the clinic for a short time, after which he can safely go home.
Now let's talk about serious traumatology, orthopedics, and surgical treatment. What types of operations can be used in a patient with deforming osteoarthritis? It's all represented here on this pile. Pay attention, starting from the moments of removal of free intra-articular soft tissue cartilage, bone cartilage tissues. These are the same andromatous bodies, and nowadays it is most often arthroscopic removal techniques. A variant of resection of hypertrophied pinched synovial membranes inside. This is most often the lot of the knee joint. In addition, there is also a hypertrophied Goff body. This is a fatty body in the knee joint, which, against the background of constant chronic sinusitis, constant inflammatory processes, grows and prevents a really normal person from performing, that is, working the knee joint, performing the function. Therefore, it is also most often arthroscopic techniques for the so-called rehabilitation of the joint, when with the help of plasma, that is, electricity, we cut off the overgrown synovial membrane. Here this option is called arthrolysis or partial synovectomy. In the case of hypertrophied destruction with a local area, they can also be removed by acute resection. Osteotomy, these are the very spicules, these are the variants of outgrowths that sometimes injure soft tissues with their sharp parts, when sometimes so powerfully deforming the joint, they interfere with the proper competitiveness of the joints. They can be cut down, and a variant of this is called an osteotomy. Well, let's say we are going to consider this very broadly now. This method is used for hallux valgus, for osteoarthritis of the first plus non-Foland state, which is combined with a pronounced deformation in the area of the first finger, that is, with a valgus deformation of the first finger. The most modern technique at the moment is endoprosthetics. Yes, indeed, this is already a treatment option when we have a neglected joint situation, when in reality our own joint, described to us by nature and the Lord, has already undergone such changes when it cannot function properly. In this case, we have to change it to artificial and endoprosthetics options. This is a high-quality modern approach to restoring the functions of the well of our musculoskeletal system. The opposite option is the palliative option, which is crippling. Yes, but less and less often, of course, now used. Previously, it changed quite widely. This is the so-called arthritis, when the joint closes, when the possibility of movement in this joint is blocked. On the one hand, blocking movement, we definitely worsen the function. Joints as such already stop working. On the other hand, by reducing painful movements in this joint, we improve the quality of life of the patient. Yes, and this is a palliative surgery. So, arthroscopy of the knee joint is minimally invasive surgery. Well, on the knee joint. Let's look at it here. The advantages of these techniques, widely applicable methods at the moment. You and I are sorting out this case in class, and those methods of surgical treatment that are now in trend. That is, they are not something that can be said under the word fashionable, but they can say that it is very much in demand, it is very correct. Minimal invasiveness during arthroscopy of the knee joint. Yes, anterior internal, anterior external approaches are used. The incisions are completely small on the sides. Here are the hamstring ligaments 3 to 5 mm long. Previously, with an open technique, a fairly long incision up to 15 to 20 cm was required, arc-shaped, crippling in this case, making an ugly joint. Yes, in this case, for optics, for arthroscopic instruments, such large incisions are absolutely not needed and, say, you can do with minimally invasive, small ones. The possibility of a full-fledged diagnosis of the sweat of the knee joint is an advantage. That is, we get a video camera there and can see up close with the use of optics, yes, a fairly small sweat which we could not even detect and see before the joint was opened wide. A short period of rehabilitation, that is, a minimally invasive approach to surgery on such a large joint as the knee with small incisions suggests that the patient is rehabilitated very quickly. That is, an early supporting load on the limb, that is, walking without additional support, depending on what we did inside the joint, it is possible either immediately, that is, on the first day, or with all my desire, on the third day. I often allow the patient to walk fully. That is, the terms of disability are decreasing, and for the state, yes, for our society, this is critically important. That is, from the average from 4 to 6 weeks, that is, when some, well, say, operative techniques were performed on the joint until the last 2 to 3 weeks, and with a sports injury, it is possible to start training quickly enough to compete. I do not argue. I am a small supporter of professional sports from the outside as an orthopedic traumatologist. We are well aware that this is, say, a large volume of our, well, social life, yes. Reducing the length of hospital stay during arthroscopy, that is, the ability to use the option of a day hospital, the ability to most often use not necessarily large wide-profile clinics, and this may still be the lot of small clinics. Discharge from the hospital usually occurs on the first or third day after surgery, yes, and with an open method, the patient was usually at least 14 days before the stitches were removed, and sometimes more. The usual story about osteotomy, yes, on the example of a hallux valgus deformity of the first toe. On the example of the situation when we have a valgus deformity combined with osteoarthritis of the first metatarsal phalangeal joint. Well, that is, an osteotomy is a dissection of a bone. This is a typical orthopedic operation, which is used to correct the deformation of long bones and the incorrect position of the limbs. Yes, that is, in this case, pay attention to the hallux valgus, one of many. Here we have hundreds of variations of the approach to this process. Yes, when the operation is performed and the situation before the operation and the variant of how the limbs look after the operation, after some part of the bone is cut off in the area of the so-called bump. Yes, some part is wedge-shaped excised and, as a consequence, the axis is restored in the normal physiological direction. The axis of the first toe, the axis of the first metatarsal. As I have already said, arthritis surgery is a palliative. There is an operation that, on the one hand, is crippling, which takes the joint completely out of motion, and it ceases to function, but sometimes it is necessary. Arthritis is an operation that creates complete immobile joints in order to restore the lost in some diseases and damaged musculoskeletal ability. Here in this case, pay attention to how the first plus is closed, not the phalanx joint. As such, the flexion-extension function will be lost here, but the pain component will go away and the actual supporting function of the foot will be restored. A person will be able to step painlessly on this zone. Yes, I do not argue. That is, it may not be very pleasant for him to run and jump, there will be some restrictions in walking, in gait, but the function of walking in general will be restored by itself. Endoprosthetics. The operation itself was first tested for the replacement of the hip joint. It happened a long time ago, the process is progressing. Now this operation is moving from the category of rare to the category of fairly ordinary operations that are performed in various clinics, in particular, in the same KB8. There was a time when they were performed, but now for various reasons it is somehow not being done, but I will clearly say that the same Kaluga hospitals are actively performing these operations. I have something out of the ordinary. We analyze our own in detail in the classroom, we always have the opportunity to make a report on this topic. You are with all the desire in the practical, and in practical classes, listen to the whole thing, understand and see. About the joints, it should be said that not only the hip joint is being replaced, but there is a long-established method of knee arthroplasty. This is how the endoprosthesis looks approximately, and so it is installed in a person. The same situation with the shoulder joint. It appeared a little later than the knee replacement. The technique is not frequent, because the shoulder joint itself is less susceptible to, say, osteoarthritis, but the option is possible both for diseases of the shoulder joint and, let's say, injuries when the joint can be replaced. Here, you see, is a partial replacement of a fragment of the head of the joint which borders and replacement of the articular surface of the scapula. Yes, oddly enough, such a terminator exists in nature and these operations have been carried out for a long time. There is a variant of metal interflank joints, there is a variant of polymer interflank joints, and these joints are also being replaced. Right here, the metacarpophalangeal joints, you see, have been replaced. Endoprosthesis of the first plus non-phalangeal joint. Now we have just talked about the arthrodesis option in this case, but here we are talking about the fact that in the process of corrective surgery, in particular the same hallux valgus, there are options for replacing this joint with an artificial one. As a result, we will retain mobility in the first plus-sized joint. Yes, we will perform a correction of the correct shape. You see, here, yes, we have the phenomenon of osteoarthritis and a slight, however, deformity, and we will stop the function of this joint by replacing it with art. A more complex joint, one of those that appeared quite recently, because there were real technical difficulties with trying to create, well, let's say, an endoprosthesis of this joint is an ankle joint, and this is how an ankle joint looks like. Here is the latest thing that, say, medical science has given out. This is the replacement of the elbow joint. If you remember the anatomy, the elbow joint is the most difficult joint of our body. Indeed, medical engineers had to puzzle over how to make it. Well, after all, they created it, they did it. Here we have an endoprocess of the elbow joint. Let me finish with this. Thank you for your attention.